My name is Dr. Adrian Minson, and I'm a Lymphoma Fellow at the MacCallum Cancer Centre and Royal Melbourne Hospitals in Melbourne, Australia. I'm undertaking a PhD in clinical trials that are designed to explore novel immunotherapeutic combinations in aggressive B-cell lymphomas. The question I'm discussing today is the role of combining targeted therapies with CAR T-cells in mantle cell lymphoma. As we're all aware, relapsed mantle cell lymphoma can be a very difficult disease to treat, and we remain in need of improved therapies that can lead to durable remissions for our patients. Targeted therapies, such as ibrutinib tyrosine kinase inhibitors, are highly active and revolutionize the treatment of relapsed mantle cell lymphoma by allowing patients to avoid the toxicity of further cytotoxic treatments. But their effect is generally time limited, and most patients eventually progress on these agents after 2 or more years. Until recently, outcomes after BTK inhibitor failure were very poor. The latest exciting developments in mantle cell lymphoma have been the immunotherapeutic agents, and mantle cell lymphoma is highly sensitive to these treatments. Key drugs in this class include T-cell redirecting therapies, such as chimeric antigen receptor T-cells, in which a patient's own T-cells are genetically modified to recognize and destroy cancer cells, and the bispecific antibodies, which form a bridge between T-cells and tumor cells, resulting in the same outcome. Both CAR T-cells and bispecific antibodies can produce high rates of complete responses in patients who have failed BTK inhibitors, somewhere in the realm of 60 to 70%. Yet these agents have their own limitations. Firstly, they are associated with significant toxicity, such as cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome, which can be quite severe in around 1/3 of patients treated with the currently available CAR T product. Secondly, we know from large retrospective studies that relapsed mantle cell lymphoma is an aggressive disease for many patients, and up to 40% of patients progressing on a BTK inhibitor may never receive a further therapy. Therefore, novel immunotherapies such as CAR T-cells are not available or appropriate for all patients. There is room for significant innovation to make CAR T-cell agents more tolerable, more effective, and to use them earlier in the treatment sequence to try to get the most benefit for the greatest number of patients in need. One way to potentially achieve this is through the combination of targeted therapies with CAR T-cell agents. A promising therapeutic cocktail is the use of a BTK inhibitor together with a CD19-directed CAR T-cell product. There are a number of potential benefits to this strategy. Firstly, both BTK inhibitors and CAR T-cells are independently effective in mantle cell lymphoma, and therefore there is a potential simply for additive benefit. But more importantly, BTK inhibitors, such as ibrutinib, have additional effects on other important cellular development and regulatory pathways. For instance, ibrutinib also inhibits ITK, which is an important pathway in T-cell development. Studies have shown that long-term exposure to ibrutinib can improve T-cell health and fitness in patients with lymphoma or leukemia, and therefore it may positively affect the CAR T-cell product when it is manufactured from the patient's own cells. A number of groups have studied the combination of ibrutinib and CAR T-cells in chronic lymphocytic leukemia and have shown that the combination can result in more robust CAR T expansion, high rates of response, and lower rates of CAR T-related adverse events, such as cytokine release syndrome. Our own group at MacCallum Cancer Centre, in combination with a number of other sites across Australia, tested this same combination in 20 patients with mantle cell lymphoma, whose disease had relapsed after at least one prior line of treatment. Patients were treated with ibrutinib, which started before the T-cell collection that was used to manufacture the CAR T product. Patients then received a single dose of CAR T-cells and continued the ibrutinib for 6 months, at which time it was ceased. Through this study, we demonstrated that the combination resulted in a complete response rate of 80% at 4 months after infusion. And with a median of 13 months of follow-up, a progression-free survival rate of 75% at 12 months, and overall survival of 100% was achieved. Importantly, this combination appeared to work in patients with high-risk features, such as those whose mantle cell lymphoma harbored TP53 mutations, which generally predict for poor responses to both chemotherapy and targeted treatments. Cytokine release syndrome remained a common event experienced by 75% of patients. However, neurotoxicity was very rare, seen in only one patient, and was completely reversible. Overall, both prior groups' work and our own study suggest a promising role for the combination of targeted therapies with CAR T cells in mantle cell lymphoma. Additional combinations of CAR T cells with other targeted agents with immunomodulatory effects, such as lenalidomide, for instance, could also be attempted. Finally, combining targeted therapies like ibrutinib with other T cell redirecting therapies, such as the bispecific antibodies, is a further area warranting exploration. Thanks for your attention.